Welcome back. It's 3:30 by our studio clock, and this is teleconferencing program which is jointly conducted by Indira Gandhi National Open University and National Board of Examination. This is the second session of our today's program, and in this particular session our expert is Dr. Deepak Bhattacharya. Dr. Deepak Bhattacharya is a senior chest physician in Vardhaman Mahavir Medical College and Safdarjung Hospital, and the topic of this session is interstitial lung disease in collagen vascular diseases. If you want to ask anything about this particular topic, you can make a phone call and ask your queries from Dr. Deepak Bhattacharya. Numbers are same 011, which is our STD code, and numbers are 29532844 and 29532845. You can use our toll-free number also, that is 1800112345. If you want to download the forms of National Board of Examination, you can visit our website. The website is www.netboard.edu.in www.netboard.edu.in, and to get the DVDs of any of our teleconferencing programs, you can contact National Board of Examination. This program is jointly conducted by Indira Gandhi National Open University and National Board of Examination. And right now, I would like to request Dr. Deepak Bhattacharya to start the session about interstitial lung diseases in collagen vascular diseases. Dr. Bhattacharya, please.
Good afternoon, viewers. By now, you would have got an idea. For the past two sessions, that is the last session, we had taken up a general discussion on various aspects of interstitial lung disease. And today we are touching on some specific topics related to interstitial lung disease. Dr. Sen spoke about UIP in general, that is IPF. I'll be talking about the interstitial lung disease in collagen vascular diseases. You would have noticed by now that all of these, they basically follow a certain format. And the variation of the presentation in various diseases, that is what we'll try to highlight and try and tell you if there is a difference in the treatment management in specific to the various disease groups we are discussing. So I am going to discuss the collagen vascular diseases, ILD in collagen vascular diseases, and I'll give you a brief outline of what is this collagen vascular or collagen tissue diseases. Now they are autoimmune diseases. The exact cause remains unknown. There are different diseases associated with specific autoantibodies. That is when some part of the body is being recognized as the body as non-self. That is when the problem starts. And collagen vascular diseases are associated with perivascular collagen deposition. As you'd see from here, there is a list of collagen vascular diseases. It's an incomplete list. They are systemic lupus erythematosus, Rheumatoid Arthritis, Sjogren syndrome, systemic sclerosis, Polymyositis and Dermatomyositis, mixed connective tissue disorders, and Wagner's granulomatosis. And all of these have certain specific autoantibodies which help us also in diagnosis in addition to their clinical features. Now the symptoms are often non-specific and overlapping, therefore they are at times difficult to diagnose. Lung involvement in CVD-ILD is associated with significant morbidity and mortality, and there is various tissue distribution and pattern of organ involvement. In the histopathology, the connective tissue and blood cell inflammation and abundant fibrinoid deposits are there. And because of the improved management of systemic diseases with better survival results, there are more patients who are developing pulmonary fibrosis, and a large number of these patients are still subclinical. Now coming to the prevalence of pulmonary fibrosis in collagen vascular diseases, pulmonary fibrosis is the most common cause of death in many collagen vascular diseases. Prevalence vary widely and depends on the method of detection. Clinical symptoms are unreliable. X-rays are also insensitive. Therefore, prevalence, if you compare symptoms vis-a-vis HRCT, you would find in collagen vascular disease by symptoms, if it's 1 to 5%, by HRCT it would be more than 20%. HRCT is by large the most sensitive tool and demonstrate about 20 to 50% involvement in most collagen vascular diseases. And biopsy and autopsy is fraught with selection bias, therefore it is not used as a tool for prevalence. Now coming to specific prevalence rates, in systemic sclerosis, pulmonary fibrosis is the most prevalent in systemic sclerosis, and with pulmonary hypertension is the most common cause of death. The clinical symptoms in systemic sclerosis related to the chest is present in 30% of cases, but pulmonary fibrosis, if you do by HRCT, is present in up to 70% of cases, and up to 90% of abnormal PFTs. And X-rays and HRCTs are taken in toto are suggestive in 65% of cases. In rheumatoid arthritis, clinically significant pulmonary fibrosis is not very common in rheumatoid arthritis, but DLCO, if you take, which is a very sensitive indicator again, is decreased in 20 to 30%. In one study, when open lung biopsy was done, pulmonary fibrosis was seen in 60%. But as we said, there can be a bias in taking open lung biopsy because only very symptomatic patients are taken from the open lung biopsies. In polymyositis and dermatomyositis, clinically overt pulmonary diseases are found in around 30% of patients. In systemic lupus erythematosus, limited clinically insignificant involvement is seen in up to 30% of cases. Clinically significant, that is X-ray evidence, is only seen in 5% of patients. IPF in general in SLE is one of the most uncommon in the collagen vascular diseases. 5% of the SLE develop progressive pulmonary fibrosis on follow-up. In Sjogren's syndrome, 10% clinically significant pulmonary fibrosis in primary systemic in Sjogren's syndrome, with up to 35% in HRCT is seen. In ankylosing spondylitis, associated with the limited non-specific upper zone fibrosis and bullae on HRCT, and clinically most of them are insignificant. Now, after this, we will be discussing in detail about the pulmonary fibrosis and various aspects related to the effect of collagen vascular disease in pulmonary fibrosis. Now, Scleroderma, to the first disease to be taken up, it is also known as systemic sclerosis. Sclerotic skin changes are often accompanied by multisystem disease. Progressive fibrosis with increased collagen deposition in interstitium and intima of small arteries and connective tissue. This is the histopathological hallmark. May be benign cutaneous involvement or aggressive systemic disease. There are 4 to 12 new cases per million per year, and there is a female preponderance of 3 to 4:1, and the average age of onset is between the 3rd and the 5th decade. Now, what are the predisposing factors? There is no relationship between the systemic and the pulmonary disease. There is a genetic association. Presence of HLA, DR3 and 52A increase the chances of systemic sclerosis. The pulmonary disease is more common among Caucasians with systemic sclerosis. There are various autoantibodies which are seen, like anti-topoisomerase antibody, anti-RNA polymerase antibody, and anti-centromere antibody. You would find as each of these antibodies is associated with specific features, like anti-topoisomerase has more of pulmonary fibrosis, anti-polymerase antibody is linked more with cutaneous and renal involvement, and the serological markers are mutually exclusive. Systemic sclerosis, pulmonary fibrosis seen with systemic sclerosis is associated with several environmental agents which sort of expose the patient to pulmonary fibrosis, and there are several of them like D-penicillamine, tryptophan, bleomycin, pentazocine, vinyl chloride, etc. Now, coming to the pathogenesis, chronic inflammation leads to progressive lung injury and incremental fibrosis. Accumulation of connective tissue in the lung is initially triggered by environmental factors, and subsequent amplification of the immune response occurs in the genetically susceptible individuals. Now, in these individuals, several mediators have been noted, like transforming growth factor beta, TNF alpha, connective tissue growth factor, T helper cells 1, and there are several factors which are seen in the bowel fluid in these patients, like IL-8 and MIP-1, that is macrophage inflammatory protein 1. Now, the pathogenesis reflects an alveolar epithelial cell injury, inflammatory cell recruitment activation, and differentiation into myofibroblast with accumulation of matrix proteins in the interstitium. Now, coming to the pathology, initially histology in CVD-ILD was thought to be similar to IPF, that is UIP, but recent evidence suggests that there is more similarity to a non-specific interstitial pneumonia, with cellular non-specific interstitial pneumonia in a small group who have shown a better response to therapy. In a small group, that is less than 10%, show a UIP pattern, though prognosis is not very different in the UIP and the NSIP group. In the group following deep penicillamine therapy, histology is similar to organizing pneumonia with increased incidence of superadded infections in this group, and there is also increased chances of malignancy. Now coming to the symptoms, in the head and neck symptoms, dysphagia is the most common initial complaint in systemic sclerosis. 80% exhibit pathology in distal two-thirds of esophagus on barium swallow, decreased or absent peristalsis, hiatus hernia and reflux. These patients have tight thin lips with vertical perioral furrows, trismus secondary to tight skin and not due to temporomandibular joint pathology. There is zero stomia and zero ophthalmia, that is, there is a dryness. Laryngeal involvement is there with hoarseness. Transition zone around dental roots, this is considered to be a very important sign to diagnose the disease. Now here is a photograph of a lady with systemic sclerosis. You can see the tight skin, the taut skin, the thin lips, the furrows, and here is the changes that you see on the foot. Similarly, here you see a barium swallow in which there is a reflux and there is a dilatation of the lower end of the esophagus and the changes in the finger. And in this patient, there is also evidence of clubbing, which is somehow not very common in most of the diseases, in most of the systemic sclerosis patients. Now coming to the clinical features in specific to the respiratory system, it usually presents a dyspnea which is enhanced due to the presence of myopathy, arthropathy and pulmonary hypertension. There is a resistant cough which should lead one to exclude secondary Sjogren syndrome and reflux. Clinical findings similar to IPF with basal crackles, tachypnea, cyanosis and right heart failure is the usual hallmark of the disease. Usually clubbing is not present and lung involvement may often precede the systemic involvement. Now the investigations to diagnose systemic sclerosis, pulmonary fibrosis associated with systemic sclerosis, you will find in most of the diseases that we will be discussing, we use the general similar tools, that is the PFT, the X-ray, the HRCT and the bronchoalveolar lavage. Now in systemic sclerosis, PFT shows a restrictive defect with greater decrease in DLCO. The DLCO is a very sensitive indicator and correlates well with the lung involvement. Isolated decreases in DLCO is seen in subclinical involvement. Decrease in DLCO is associated with pulmonary vascular involvement. In the X-ray, which is a poor indicator in systemic sclerosis, often you can get a normal X-ray which, if symptoms still suggest, patient should be investigated further. However, the HRCT is a very sensitive indicator which initially shows in the initial phases lower zone ground glassing with reticulation and traction bronchiectasis suggestive of the NSIP pattern. However, in some there can be ground glassing without traction bronchiectasis suggestive of the cellular type of NSIP. BAL, however, is not very useful in systemic sclerosis, and however the neutrophilic or the eosinophilic BAL is associated with a poorer prognosis. Now this is a patient in which there is this HRCT cut which is showing a ground glassing opacities. Now this is another X-ray in which, if you see, you can see on the X-ray the peripheral subpleural involvement and there is a dilatation of the esophagus. This is a very important sign on an X-ray and a CT which could suggest the presence of systemic sclerosis. The same thing you can see on the CT. If you see, here is the trachea and you can see the esophagus which is much more dilated than is normally noted, and here again you can see the reticular shadows which are subpleural. The prognosis and natural history of the disease. Prognosis in pulmonary fibrosis and systemic sclerosis is, as in all collagen vascular diseases, is linked to the severity of the pulmonary disease. The 10-year survival is around 70% in similar lung involvement. However, it is better than in IPF. The DLCO is linked to morbidity, and a less than 40% decrease has a less than 10% 5-year mortality. Patients with early systemic disease, severe disease or deteriorating disease would suggest a patient with a poor prognosis. Now the second disease we take up is rheumatoid arthritis. This affects 1% of the population. Women again are affected 2 to 3 times more than in men. The age of onset is in the 4th and the 5th decade. There is a juvenile form which is called the Still's disease. The inflammation of the synovial tissue, and which is mainly lymphocytic with synovial proliferation, is the hallmark of this disease. Symmetrical involvement is there, and usually the peripheral joints, the smaller joints of the hands, feet and wrists are involved. There are occasional systemic effects like vasculitis, visceral nodules, Sjogren's syndrome and pulmonary fibrosis may be seen. This is associated with an anti-RA33 autoantibodies, and rheumatoid arthritis is also associated with rheumatoid arthritis associated nuclear antigen is also seen. Like in systemic sclerosis, host susceptibility and environmental triggers interact to initiate pulmonary disease. In this, the rheumatoid arthritis is often associated with HLA-D8 and HLA-DW3. The risk of pulmonary fibrosis increases with rheumatoid factor increase in rheumatoid factor titers and rheumatoid pulmonary nodules. Smoking enhances the chances of pulmonary fibrosis in rheumatoid arthritis. Pulmonary fibrosis in rheumatoid arthritis is enhanced by secondary causes like atypical pulmonary infections like mycobacterial infections, cytomegalovirus, pneumocystis carinii, especially when immunosuppressive drugs are used. Now coming to the pathogenesis. Pathogenesis of pulmonary fibrosis in rheumatoid arthritis is similar to that in other ILD CVDs, with accumulation of inflammatory cells, particularly the T lymphocytes and macrophages with immune dysregulation. There is a protease antiprotease imbalance, and it is associated with the recruitment of matrix secreting cells together with altered repair mechanisms and generation of profibrotic milieu. Now, the pathology in pulmonary fibrosis in rheumatoid arthritis, it is associated with the early lymphocytic interstitial infiltrate with predominant pedibronchial follicles which progress to fibrosis. Now, in rheumatoid arthritis, at times all types of pictures could be seen, but most commonly it is present is a UIP pattern with subpleural reticular pattern and honeycombing. However, the interstitial pattern could be that of UIP, NSIP, and sometimes suggestive of organizing pneumonia or LIP. The rheumatoid pulmonary nodules may at times cavitate. Follicular bronchiolitis is more responsive to therapy if present. Some patients with rheumatoid arthritis develop diffuse alveolar disease and with a poor prognosis. There are certain other pulmonary manifestations that could be seen in pulmonary fibrosis associated with rheumatoid arthritis, which are a pleural involvement, that is presenting as an effusion or a thickening, as rheumatoid pulmonary nodules, drug-induced pulmonary fibrosis, bronchiectasis, pulmonary infections, Kaplan syndrome, and rarely pulmonary vasculitis. Now, this is a histopathology slide of a patient with rheumatoid arthritis associated pulmonary fibrosis, where if you see there mainly the lymphocytic infiltrates and the evidence of pulmonary fibrosis, and you can see the nodules here. Now, the clinical features of patients with rheumatoid arthritis. Clinically significant pulmonary fibrosis in rheumatoid arthritis occurs between 50 to 70 years of age. Pulmonary fibrosis in rheumatoid arthritis usually presents with insidious dyspnea. Pleural disease is associated with chest pain and occasional fever. Airway involvement is associated with a non-productive cough. On examination of these patients, one would get a fine end expiratory crests. Clubbing is seen. This is one pulmonary fibrosis in which clubbing is more common than in others. It is seen in advanced rheumatoid lung in contrast to other CVD ILDs. In 10 to 20% pulmonary symptoms precede the systemic features of rheumatoid arthritis. Now, again here are diagrams showing the changes in the small joints of the hands and the rheumatoid nodules that is seen here. You can see very clearly. And similarly, you can see, unlike in systemic sclerosis where I said the TMJ joint is not involved, in rheumatoid arthritis the TMJ joint could be involved, leading to difficulty in opening of the mouth. 55% of TMJ joints are affected, 70% with radiologic evidence of TMJ involvement, and juvenile form may also lead to retrognathia. Now, investigations, again we follow the same pattern as in the previous diseases we have talked about. PFT shows the restrictive pattern with reduced lung volumes and DLCO. The subclinical diseases is seen with isolated decrease in DLCO. Presence of an obstructive pathology suggests an associated obliterative bronchiolitis, bronchiectasis, or smoking related pathology. An extrapulmonary restriction is noted in pleural disease. In the X-ray, it may show a patchy alveolar opacity, reticulonodular densities, and honeycombing. Pleural abnormalities and cavitating rheumatoid nodules support evidence of rheumatoid lung. On the HRCT, usually it reveals an UIP pattern with peripheral reticulation and microcystic changes, that is honeycombing, indistinguishable from IPF. The NSIP pattern would show traction bronchiectasis. There may be a multifocal consolidation with florid ground glassing seen in organizing pneumonia, and obliterative bronchitis is associated with the mosaic attenuation due to bronchitis, bronchiolitis, and vasoconstriction. Follicular bronchitis, which is more responsive to therapy, as I said, shows micronodular opacities and a tree in bud appearance, something that often can be also seen in tuberculosis. It needs to be differentiated from. BAL in rheumatoid arthritis is again non-contributory. Here is an X-ray in which you would see that if one is shown this CT film, a CT cut, it is very difficult to differentiate the pulmonary fibrosis in rheumatoid arthritis from that of a UIP. There are peripheral reticular nodules with honeycombing. Prognosis and natural history in rheumatoid arthritis. The clinical course in rheumatoid arthritis is heterogeneous and linked to the disease severity. The more severe disease is usually insidious in onset, chronic and progressive. Infective complications are the leading cause of mortality in rheumatoid arthritis, accounting for up to 20% of deaths, and many patients with subclinical fibrosis remain stable on follow-up. Polymyositis and dermatomyositis, groups of disorders. This is characterized by proximal muscle weakness and non-suppurative inflammation of the skeletal muscle. The prevalence is 5 cases per million per year. Again, there is a female preponderance of 2:1, and the usual age group is 40 to 60, but there is a pediatric variant. Predisposing factors and pathogenesis. There is a combination of diffuse lung disease with myositis and arthritis is associated with autoantibodies. In this, the autoantibodies are seen to aminoacetyl tRNA synthetases and histidyl tRNA, that is JO1, is present in 30% of patients with inflammatory myopathy, and in over 50% of patients with inflammatory myopathy is associated with the diffuse lung diseases. Other anti-RNA like PL2, PL7, EJ and OJ are also noted, and there is in this disease no genetic association has been found. Coming to the pathology, the pulmonary disease in polymyositis, dermatomyositis is associated with the NSIP pattern most commonly. Sometimes it is associated with or preceded by the organizing pneumonia pattern. Coexistence of organizing pneumonia and NSIP pattern is associated with a worse prognosis. Potential complications are respiratory muscle weakness due to active myositis and infection secondary to pharyngeal muscle weakness and aspiration pneumonia, and this is associated more with use of immunosuppressive therapy. ILD in polymyositis and dermatomyositis is associated with increased risk of malignancy. Now, the clinical features in these are associated with absence of symptoms to rapidly progressive dyspnea associated with organizing pneumonia, NSIP and diffuse alveolar damage. In 30%, symptoms of pulmonary fibrosis predate the systemic symptom manifestations, and myositis is associated with increased dyspnea due to respiratory muscle involvement with risk of ventilatory failure. There could be significant cough, which suggests the possibility of aspiration pneumonia in 20% of patients. And clinical examination is similar to that in other CVD ILDs. Now, here is a photograph of a patient. You can see very well the presence of the inflammatory polymyositis. It's the red color of the muscles on the thigh. This is also typically associated. Dermatomyositis is a heliotropic rash, that is a dark discoloration around the eyes. On investigations, on PFT, again it shows a restrictive defect with decreased lung volumes and DLCO. The restrictive defect